I will provide a short introduction and then we will continue with the main speakers. Being an overachiever in a strict school system where only perfection was accepted, I still remember the maak nalatige foute, negligent mistakes. This opinion earned me the rot at home too. Neither helped my spelling. I needed special software long before the time of software. Assistive devices from low to high tech can assist many of us to be the best version of ourselves, but their provision must fit seamlessly into the larger ecosystem of which we are a member. Today we will share some thoughts on how assistive devices can be provided according to an ecosystemic approach and what the possible advantages of that might be. After an introduction on assistive devices and their place in global health from me, Ilana will share her lived experience as an assistive device user and how AT can unlock potential and facilitate social determinants of health. Anna will then follow with a description of a project rolled out in parts of South Africa where an ecosystemic approach was used from planning through inception to assessment while wheeled mobility assistive devices were provided. We are aware of the benefits of assistive products in the lives of individual people. We might have personal experience or close familial experience of what a pair of spectacles can do, how it enhances daily functions like reading, writing, and driving a car, things that in turn help us do our work, excel in school, order in a restaurant, read the dosage on a pill box. In short, assist us to do the things important to us and thus improving our lives and the quality thereof. Another example comes from the field of neurodiversity. Persons with neurodiversity has immense potential that often remains untapped since they struggle to function in what others see as normal environments and doing what others see as everyday activities. My poor spelling being an example. They are labeled disruptive, lazy, careless, negligent. With devices and inclusive technologies such as noise-cancelling headphones, organizing and planning programs, spell and grammar checks, speech to text, and numerous others, their potential can be unlocked, and they can use the energy to develop and create, instead of being diverted by office noises or typing difficulties. For helping individual people becoming the best version of themselves, assistive devices help communities and countries flourish. They help facilitate global health. An assistive product is both a social determinant of health and a way of positively impacting social determinants of health. Take the example of spectacles or tools for people with neurodiversity further. They are enablers during education, for employment, to access health information, and much more. As such, AT devices influence material circumstances and living conditions positively, and thus, by implication, social determinants of health and global health. From here, it is easy to see how appropriate population-level access to assistive products is essential to achieve the Sustainable Development Goals. If a person with impairments are left behind in education because they do not have access to products that allow them to flourish in schools, such as spectacles or the above-mentioned software, or hearing devices as Ilana will show, or many other devices, they might be relegated to the margins of the economy, doing often dangerous menial jobs for less pay and without medical insurance and other security nets. Threats to global health all around, and a barrier to achieving Sustainable Development Goals. The low income forced them into poor living conditions, dangerous neighborhoods, exposure to polluted water and air and water. Disease risk increase, as with the recent cholera outbreak. It creates barriers to healthy nutrition. And so the picture of risk and deprivation and poor health and well-being for families, communities, and societies evolved. A negative spiral that in some instances could have been stopped with the provision of an assistive device while attending to the ecosystem around the person. Before we look at the larger ecosystem, just a word on appropriate. Any device will not do. It's as simple as the slide says. You do not go running in your heels. You do not go swimming in your tux, not if you're sober anyway. You cannot hear so well with grandma's hearing aids. An appropriate assistive product does not come in one fits all. Unfortunately, it is often reduced to that. Go and buy a wheelchair discount. They are cheap. Cheap for whom? In the long run, the cheap chair hampers function and thus education, employment, all the other things that I've mentioned. It might actually lead to poor health as secondary complications might develop. Pressure ulcers, contractures, musculoskeletal deformities, to name a few related to wheelchairs. However, wheelchairs serve as an example, and the reality holds true for many other devices. Most people will need assistive devices in their lifetime. The user spectrum is wide and growing due to population aging. As we age, our physical, sensory, and mental abilities decrease. We will need canes, hearing aids, spectacles, pill organizers, reminders, and it goes on. But aging is only part of it. As perinatal health and treatment of previously mortal diseases such as cancer improve, children and adults survive with impairments of the body and or mind. These can sometimes be mediated by assistive technology. Antiretroviral therapy is another very South African example. Yes, people survive longer with it, but often with neurological fallout that might require assistive technology. So assistive technology involves all of us, no matter our speciality. If the patient we treat have impairments, we must consider referral for appropriate assistive technology. And we must remain responsible that the assistive technology is provided over time and place for the rest of that person's life. As the child moves from school to tertiary education, a different wheelchair might be appropriate. More software might be needed. Moving then into employment, an adapted vehicle might be needed. The workstation might need specific devices. Coming retirement, the wheelchair will need to be changed again to accommodate for deterioration of musculoskeletal system and strength. Currently, assistive technology is provided in silos through a medical approach, if provided at all. It is seen as something like medical, like drugs or surgery, to try and cure or better the medical problem. One therapist provides a wheelchair, another a hearing device. The optometrist gives spectacles, and so the patient moves from place to place and provider to provider in an ongoing dance to get what they need. The services are seldom coordinated, and little or no emphasis is placed on the factors around the device that can influence its use and functioning. This is where an ecosystemic approach can assist. An ecosystemic approach emphasizes the complexity, interrelatedness, and interdependence between individuals and the social context in which they function. Ecosystemic interventions is embedded in the environment. It builds on the environment's strengths and responds to its needs and fluctuations. Teachers, parents, peers, co-workers, service providers all play a role in ensuring overall successful integration with the device. Take attitudes, part of the macro system, the light green band in the figure, but lived out by peers and others in the micro, meso, and exosystem. If negative attitudes about a specific device permeate a society, it will not be used. Thus, while providing the device, interactions focusing on attitudes must also be implemented. More about this from Erna later. It is now my pleasure to introduce Ilana Solomon. Ilana completed her Master's in Human Rehabilitation Studies at our faculty in 2022, but she will tell us more about herself. Thank you, Ilana. You can take over.
Hello, everyone. Thank you, Savannah. And it's such a privilege to be here at the Global Health webinar. My name is Ilana Solomon, and on the screen is a photo of my graduation. And this was taken recently in March 2023, when I graduated with, from the University of Stellenbosch with a master's degree in human rehabilitation studies. I'm an occupational therapist by profession, and I'm currently working at American School for Deaf and Hard of Hearing. And the aim of the talk, my talk for today, is to share my personal journey with a focus on assistive technology and how the ecosystems interacted to support me in living my dreams and potential. Next slide, please. I grew up in Cape Town into a supportive, loving, and caring home. I lived with my parents and older sister. My parents suspected something wrong with their baby when I was 9 months old. And as I was not responding to voices and sounds, an initial test showed no evidence of hearing loss. And as I grew older, I continued to miss developmental milestones. Speech therapy and physiotherapy did not make a difference. And at the age of 5.5 years, after many years of seeing various professionals and being told that there was no evidence of hearing loss, I was finally diagnosed with a profound sensory neural hearing loss in my right ear and a moderate to severe sensory neural hearing loss in my left ear. My parents were devastated as they felt that the late diagnosis of my hearing loss had disadvantaged their child. Next slide, please. On the screen, there are 2 audiograms, one for the right ear and the other one for my left ear. I'm not an audiologist, but I will try my best to explain. So an audiogram is a visual graph or a tool that can be used to understand sounds we can hear or can't hear, based on hearing thresholds. And as you can see on my right ear, on the left side of the screen, I have a profound loss. Then, and the red line shows my hearing loss was nearly at the bottom and of the graph. And this shows that the softest sounds I was able to hear was a lower ma. And I was only able to, I was unable to access speech and speech sounds on top of the graph. And when one is unable to access the speech sounds, then like then it will be difficult to build words and construct sentences and eventually communicate verbally. So this type of loss was impossible for me to hear and learn spoken language. And the same goes with my left ear, which was on the right side of the graph, which was it's slightly better, but still not good. Next slide, please. So the degree and the type of hearing loss determines the type of assistive technology. I was fitted with a hearing aid on both my ears, and this picture of a hearing aid on the right side of the screen, this was the one that I used many years ago. So hearing aids are a type of technology that are worn behind the ear, which amplifies the sound so that person with hearing loss can hear and understand speech. So in the graph in the middle, there's a line that got AAA, which means it's aided with hearing aids. And so the hearing aid amplifies the remaining sounds that I have, and it enabled me to access the speech sounds and to be able to develop language. Yeah, next slide, please. I was fitted with hearing aids, now what? And this was not the end of my hearing loss journey. The impact of hearing loss is broad and it can be profound. And they include delays in speech and language. And this is an area that impacts on me in a profound way, which determines the type of schooling and services I needed. It's important to note that the first 3 years of a child's life is a critical stage for language acquisition, and undetected hearing loss have a direct impact on a child's speech and language development. So due to the late diagnosis of my hearing loss, I had significant delays in my speech and language, and therefore was referred to the Carl Tutor Center for Rehabilitation and Specialized Education. Next slide, please. Carl Tutor is situated on the grounds of Targetback Hospital, and this is a picture of the entrance of Carl Tutor. It's a school where deaf children learn to speak using hearing technology, and a center that provides early intervention programs with the focus on parent support. The school follows an experiential learning approach, and the program is language enriched. The learners are taken outings or participate in theme activities, and through that it helps us develop language skills. And the class size are a lot smaller, and we had more individualized attention to address language delay and improve listening skills. So I was in the class of 4 learners, well, 5, it was me and 4 boys, and our teacher was incredibly supportive and caring. She was in communication with my parents, and my parents would receive and copies from a teacher regarding language and vocabulary that they can work at home. And Carl Tutor has a system called parent guidance, and families get allocated a parent guidance person, as a parent guidance teacher, and they believe that parents' involvement is critical. And through the team, they provide support to parents on how to nurture their child's language development and improve spoken language at home. And I remember my parents used to take off from work and during working hours and come to join me a session with the parent guidance teacher. And the parent guidance would ask my parents questions in home context. My mom used to love being in the kitchen and cooking, and my dad loves making tea and cheese sandwich. So in the session, I would grate cheese and then put the cheese in the different food colorings and learn the colors and say the word that one use in the kitchen, cheese and tea, and the parent guide would facilitate the parents what they will facilitate the session and empower the parents, teach the parents what they can improve in terms of the interaction, and that gets continued at home. And I also receive various therapies such as audiology, speech therapy, and occupational therapy. And I hate going to OT, and because of so many rock monkey bars and climbing, I used to cry. But now I'm an occupational therapist. So the team, they present every step of the way and to assist me to overcome the various challenges. And they work closely with teachers to facilitate progress in speech and language acquisition. The team at Carl Tutor, they discussed with the parents whether I should go to mainstream or special school, and they felt that I wasn't ready for mainstream school. And so I was referred to American School. As a school where classes are a lot smaller and have intensive language input. American School offers academic curriculum from grade 1 to 7 and using spoken language. And it's situated in an observatory away from noisy environments and busy roads. And that's important because noisy environments impact on hearing and learning. And the classroom acoustics are built for deaf learners. The buildings and classroom are acoustically built for optimal learning. So the first picture on the right, on the left-hand side, is a picture of a hall. It's made of wooden floors and wooden walls. And same with the classroom. And then the second picture, there's the windows have double windows, so sound from the outside can come in the inside. And then the third picture is a picture of one of the classrooms, and there's a window on top so that light can be shown through and like the teacher's face so that we can see their lips and the facial expression. And deaf and hard of hearing learners can be able to lip read to fill the gaps of the things that have been missed through listening. And then the fourth picture is in the passageway of the window shining through the passage. Next slide, please. Okay, FM system. I was introduced an FM system in grade 1. An FM system is a special wireless assistive device that assists those who are deaf and hard of hearing to hear over a distance or in a noisy background. And there are two main parts of the system. And one is a microphone and a transmitter unit, which are worn by the person speaking, the teacher. And then number 2 is the receiver. It's used by the listener, the student, to pick up the speaker's voice. So back in the days when I was in grade 1, the FM system looked up a box in the picture on the left-hand side. So I used to wear a box in my pocket, and then the cord would be connected to my hearing aid, and then the other box would be worn by the teacher, and she would put it in her pocket and clip the microphone on her shirt. So a picture on, as you can see in the picture on the right-hand side, is the lady, the speaker, wearing the microphone and the transmitter. So her voice goes through the microphone, and then they transmit the sound to the person using the receiver, the student, and then the receiver will send the sound to the hearing aid. So the FM system will keep the teacher's voice at audible level above the background noise, no matter where the child is sitting in the classroom. So without the FM, the teacher's voice gets softer with increasing distance, which makes it more difficult to hear and learn. Next slide, please. I had incredibly supportive teachers who specialize in deaf, and all of them I'm still in contact to this day. And on top right is a photo of me when I was in grade 2 with my grade 2 teacher, and her name is Mrs. Walmont. And our teachers are in constant communication with our parents. And the classrooms were a lot smaller, slightly bigger. And as you can see, the old picture at the bottom, the desks were in like a U shape, so the student can see each other and the period and follow. And as we got older, the desks and tables got spaced out to prepare, like mainstream, to prepare us for integration. And I continued to receive speech therapy to help with my spoken language skills, audiology service to monitor my hearing loss, and appropriate devices if need be, and management of the device if it's broken. In grade 6, but in grade 5, my hearing deteriorated in my left ear, the one with the better ear. And I will speak more about it in the next slide when I speak about my cochlear implant journey. And during that time, I could not hear at all, even with hearing aids. And I would sit right next to my teacher to follow at her desk to follow what's been said in order for me to learn. And in grade 7, a decision had to be made regarding what high school I need to go to. And a case discussion was done between the teachers and the parents regarding special versus mainstream high school. And I also played a role in that decision. I said I want to go to an all-girls school, an academic school where I can, so I want to go to university, and also I can thrive in my sports. So the first thing they look at, parents and the teacher would look at, is the class size of different high school. And Westernburg High School had 40 learners, and Weinberg Girls High School had had 28 learners. Yeah, and the teacher also wrote motivational letters. The school encouraged and supported parents and prepared the learners for integration into mainstream. I got accepted into Wambu Girls High School. Next slide, please. Okay, so I'm going back to grade 5 when my hearing deteriorated. So when my hearing deteriorated, I was referred to the ENT specialist and then to the cochlear implant unit at Target Hospital, where they did an evaluation and they found that I was an excellent candidate for a cochlear implantation. Next slide, please. A cochlear implant is a hearing device that provides a sense of hearing to children and adults who have severe to profound hearing loss and receive little or no benefit with hearing aids. It consisting of 2 parts. One part is surgically implanted behind the ear. So the picture on the right-hand side, the first device, that's the implant. And then number 2 is the other part, is an externally worn speech processor, which sits behind the ear, the second device on the right-hand side. Okay, so the cost of the implant was, or the device and the implant cost nearly the price of a car. At the time, it cost over 250,000 rand. And that's the device and the implant. Only there's other costs that family has to pay, which is surgery and post-rehabilitation and batteries and repairs. My family embarked on a year-long fundraising campaign for the device and implant, and much church and the school, as well as the community, also got involved. And I appeared in newspapers like the Burger and the Southern Mail. I also played the recorder at pubs to raise funds. I used to play the national anthem. And the church also had functions, such as the musical evening and donuts and coffee on a weekly basis. And in my school had cake raffles, and I used to stood at the door with money collection tins. And my parents and I were on the radio interview. And we spread information through word of mouth. And my mom sold and friends sold clothing items, second-hand clothing items. And one of my family friends organized a bus trip. Next slide, please. Surgery and post-implantation. A year later, after fundraising, my surgery took place at Vergeleken Medical Clinic in 2002 when I was in grade 6. And it was performed by an ENT specialist, Dr. Derek van der Walt. There's a picture of me with him after my surgery. And this is to implant the device against my skull and in my cochlea. So post-implantation, 2 weeks later, I attended my switch on at Target Hospital, which involves fitting of the external part, the speech processor, and activating of the device. And this was done by my audiologist. In this picture in the middle is Jenny Perrault, my main audiologist, and the lady behind her is my school audiologist. And this is to help to ensure continuation of rehabilitation at school. So my whole family was there, and it was a special day. And when the switch on of the device happened, it sounded like a radio, not right on the station. It did not sound clear as my brain still had to process the information and make sense of the sound. And every week I had to go for mapping and for programming of the implant and the device to optimize my ability to access sounds. And this was all part of rehabilitation process. And at family, at school, at home, I had to do auditory training So at home, my mother would cover her lips and she would say the sounds like bat, mat, sat, and I had to repeat after her. And that was all part of auditory training. Next slide, please. So this audiogram shows I was able to access speech sounds and even the sound of a running tap, which shows how my hearing improved after implant, with the implant. Next slide, please. The cochlear implant enabled me to enroll in a mainstream school, Wambu Girls High School, in grade 8. And it was quite an adjustment to move from a school with 80 learners to a school with 900 learners. And I worked incredibly hard and had a positive attitude. And then this picture was when I was in grade 8 with my school uniform. In the middle of the presentation is a diagram of the support that was in place. And my audiologists came to the school to raise awareness on tips of how to teach students with hearing loss, such as don't turn your back to the learner, because otherwise we can't read, and also speak slowly. It takes time to register. And also my teacher at American gave a list of tips of how to support learners with hearing loss. I wore an FM system to hear my teachers, and this was very useful because class was bigger and the buildings was not acoustically built for those with hearing impairment, even restaurants. In terms of strategies, I attended clinics for different subjects, and I also saw a private speech therapist for English, because English is one of the most difficult subjects at school. Because of my history of delays in language due to hearing loss, and that has impact later. So, so throughout my high school career, I played sports, and I played for first team cricket and second team hockey, and I also received full colours in cricket. It's one of the highest award in school. And I made the Western Province cricket from grade 8 to matric. And I used my strengths to help me overcome the challenges that comes with a disability. Next slide, please. After high school, I got accepted at the University of Cape Town. I chose occupational therapy due to my personal experience, and I could see the difference a supportive school environment could make. And I want to help others with disabilities in different educational settings. And adjustment from school to university was big. I adjusted well because I went to an academic school, and that prepared me. The lectures were huge, and one constantly get different speakers throughout the year. So I had to advocate by informing the lecturers have a young loss and explain what an FM is and discuss support needs. And through that, I became more confident in advocating for myself. And I also wore an FM system. As you can see on the right-hand side, the FM has changed. It's no more like a box. It becomes like a loop put around your neck. And then I also sat in front of the class. And university loves group work and class discussion, and that was challenging. Like in one room, you have divide the class into different groups, and it's hard because of the noise. So I had to take my group to outside the class. I can be able to participate in the discussion. And in terms of class discussion, my lecturer would repeat what the students say or the questions they ask. Sometimes, well, most times they also pass around the FM system so that I can also participate. Videos for learning and exam purposes were I had to request from the disability unit for someone to convert voice to text. Next slide, please. Yeah, employment. So something extra assistive device I use is a special alarm clock, which vibrates in order to wake me up to start my day. I'm currently working for the Western Cape Education Department at the same junior school I attended as a child, very kind school. And for me, it's a full circle, and it's wonderful to be back and be a role model and to inspire learners with young impairment to believe that they can achieve success in different areas of their life, school, education, and employment. And it's also a privilege for me to work with the principal, who was my graduate teacher. And this is the before and after picture of us, teacher, learner, and principal and OT. Next slide, please. I began my master's journey in 2021, and I really enjoyed the online learning experience. At the beginning, I told the university about my hearing loss and made them aware, and Martha set up an appointment with me, and we had a chat about support. The lecturers were incredibly supportive online, making sure the videos are on so I can repeat and follow. I use an iPad, which has a Bluetooth technology, and I also use it for my research interviews. So the iPad has got a Bluetooth, so it sends the sound voices wirelessly to my device. And it's a wonderful feature. And this was implemented about 5 years ago and has made a big difference in order for me to hear online. And the pictures below are my graduation. And yeah, the first one is a picture of me, and the second one is yes, I made it. And the third one is a picture of my mom and myself. Yeah, and my father passed away in my first year of masters, and I remember he used to watch me when I was doing my assignments, and he was so incredibly proud of what I had achieved. And getting my masters was a huge achievement for me, and I'm very proud of myself. It requires a lot of hard work and determination to get where I am today. And I'm so thankful for my parents and the wonderful support systems in my life and the assistive technology. And that made a difference. And without it, I would not be where I am today. Thank you.
Thank you, Ilana. We will do questions afterwards. But yeah, thank you very much for sharing this. I'm going to hand over to Anna van der Westhuizen. Anna is working at Shonaqua Social Enterprises. She describes herself as a social process and inclusion thought leader. Her passion lies in solving complex social problems, particularly addressing the disarmament of the voice of rights holders. Designing innovative tools in social and organizational participatory processes to facilitate social change, aiming at owning and reclaiming personal and collective narratives. So Anna, thank you. We're looking forward. Over to you.
I just want to show my face, and then I'll say hello, and then I can continue without that. So yeah, thank you, Ilana, for sharing your story. I would like to build on Ilana's story and share more stories of how assistive technology really enabled two families in particular towards inclusion. So maybe just to start by sharing a few thoughts on what is the ecosystemic approach. I think it's something we often talk about. So in our view as a social enterprise, but obviously myself as an individual also, it's really about understanding the complexity and the interrelatedness and actually interdependence between us as individuals and the social system within which we function. And by implication, it means that we also acknowledge that inclusion is not linear. So it's not something that's like a 1, 2, 3 step. And that we also say that in order to practice that, it requires both tools and knowledge, but in particularly enabling environment that Alana referred to a lot in her story. And so it for us, it recognizes that shift in perception and really patterns of thinking is vital. It's important for us to start there, but we also say it includes developing really critical mass of therapists, teachers, parents, caregivers to understand the importance of assistive technology, understanding how it can enable education, social participation, but it's also about having the conversation and kind of set up therapists, ComServes for success in the sense that they know how to do procurement of appropriate assistive technology, how can we influence the budget, allocation process, and ultimately the national tender. It also requires understanding and building awareness that all children can play and learn, and in particular also what's the role of assistive technology within that. And then finally, we believe an ecosystemic approach also definitely requires the role invite really the role of parents for practical things, besides being the ultimate support system, but also about understanding when is a device no longer suitable, how do I ask questions, what's the type of questions I ask. So the picture on the map, or the map that's on the screen right now, is kind of explaining those 4 components from number 1, raising awareness, number 2, assistive technology, training of therapists, number 3, learning and play, and then the inclusion, or the importance rather, of including parents within this whole ecosystemic approach. So the next slide, you can move to the next slide. Thank you. So I would like to share with you a project that we did within the Northern Cape. It was really about practicing what was on the map earlier. And it took a few years to get that going, with a particular partnership between us and Department of Health and some private businesses as well. So it was implemented between 2018 and 2021. And we did the work in 2 clusters within the Northern Cape. So you will see that there's Route 1 and Route 2. Route 1 was around Kimberley, and then sort of the areas around that, small towns like Danielscale and Warrenton. And then Route 2 was more on the Kalahari side, where Uppington, Kaimus, Kalfinia, Priska, those areas was included in Route 2 in particular. So and also maybe important to just explain before I continue that in many cases, in particular in Route 2, it was severe or deep rural, in cases where we only could actually get to clients by donkey cart. So that was really quite a amazing and interesting experience, and sort of understanding, if you can only get there by donkey cart, what's the implication for AT. So in the Northern Cape, the healthcare is typically provided within a district system. That's obviously mainly operated and supported by nurses, and then there's 2 secondary hospitals in the Northern Cape, but then obviously the tertiary service will be mainly outside of the provinces. I think it's widely known that within the Northern Cape there's real big challenges in terms of procurement, but also issues of a lack of a referral system. And I'm not by any way saying that this is, you know, due to incapable or staff or anything. It's really because of a lack of system, knowledge around between providers, really challenging when there's a shift in staff, very often long waiting times, little follow-up. And within that context, we walked into the project, and we wanted to focus on the 4 focal areas that I explained in the map. So that is raising disability awareness, understanding what would be a referral pathway within the Northern Cape, particularly those two routes or two routes, let me just say it like that, to provide actual wheeled mobility and 24-hour posture support devices or technology, and then also work quite closely with schools, teachers and caregivers within the Northern Cape. So on the next slide, I would like to, you can go to the next slide, please. I would like to tell a story about how does this ecosystem approach look like? So what happened actually? So I met Anita and Myla and Rebecca and Cleo when I worked in the Northern Cape in this project in particular. So without like sort of giving my perspective on things, I thought, let me share their story with you. And through that, hopefully raising the awareness of the ecosystemic approach to AT and provision around that. So you will see that Myla's a lot younger than Cleo, which was also an important part of the story. Myla was born with CP, where Cleo, as an acquired disability, came later in her life. So on the next slide, please. I want to, you can move to the next slide. I want to start unpacking. So the first part that I explained on the map in terms of changing perceptions and so forth. So what we did in the Northern Cape, in this particular project, we had Let's Talk Disability community dialogues, lots and lots and lots of them, where we have conversations about the social model of disability, different barriers that people are facing, what's the kind of local plans we can make to address those barriers. And these would typically happen within local communities. You can see here we did it under a tree. Sometimes it happens in schools, in churches, at clinics. But what I want to say, highlight here is what Anita and Myla explained, where they said lots of people don't understand disability. So we are here to teach them. Sometimes they look at they see it as a lot of work, but the person who lives with a disability gets used to it. And then both of them really explain a lot about access barriers and how transport influences their lives significantly. They talk a lot about public transport, and then they say public transport is another challenge. Not every taxi will pick you up when you have a disability. Or in many, many cases, you must make an appointment for someone to transport you. Or you have to wait for the ambulance because the patient transport can't accommodate us with a wheelchair. And then she goes on to explain that sometimes it means that they will be at the clinic at 6 and they will come back at 6 at night. But then she says, it's what we must do because how else will we get there? So she's really explaining sort of the genuine picture of the reality of access barriers. I forgot to say in the beginning that both of them live in Ritchie, a small town in the Northern Cape. So then the second thing we did within this project in the Northern Cape, in both of those routes, we did mentored outreach clinics. And basically what that means is that we would get all the therapists from each of those routes together. So for instance, we met up in Kimberley, where we did some basic product training. We did lots of skills building and assessment, and then later on fitting, but working with healthcare providers and parents. And then the same would happen in the Uppington area with lots of outreach to the small communities. Or rather, let me explain. So after the sort of bringing everyone together, we would then go to the different clinics and to the different sites where the therapists work, and we would actually work with them through capacity building. Maybe one thing that's really important to highlight, in the beginning of the project was based on the waiting list in the Northern Cape, because the vision was really to clear the waiting list. And the waiting list at that stage was 149 kids. But instinctively, we know that, that must have been a small percentage of kids. And then at the end of the project, we actually seated 350 kids with many more waitlisted. So just to give a real picture of what we know in terms of the numbers, how budgets are determined, but actually the need out there. And then they describe so beautifully here, they say the hope you have and the knowledge that you have of a disability are both so important. As parents, we hope for the best all the time, but we are also so aware of what the doctors say. Then she says, for a parent to make peace with a child's disability depends a lot on what the doctors say. The message to the people at the hospital and clinics is this: explain the child's health to the parent or the caregiver so that they will know what they must do to cope. This is really, really important for me, that we really take this from them and hear what they're saying. And then she goes on and she says, for example, they must not just to be informed that the child has a fit and that's that. They should know what to do when the child is having a fit. And then they explain there are some mothers that also have fits when the child fits, because they don't understand and they are more stressed than the child. In such situations, they can't really help the child. They are scared. And then particularly Rebecca would say, I can cope. They told me at the hospital that it's very important just to let the child breathe until the episode is over. That is what I do and it works. I share my knowledge and experiences with other mums and caregivers, which is also how Rebecca and Cleo's mum eventually met. But what's really so important here for me to highlight is that the way we explain and the way we come across sometimes when we talk to people really depends on how we say it, and that we can really choose ways in what we say that which will have a very lasting impact on us as parents, but also AT users in general. So the next slide, please. This is a quote. You can go to the next slide. Here's a quote that I wanted to share with you from them, when she said, when we got a first buggy in 2019, Milo was 4 years old. We had waited for about a year. The day we were at the church hall with all the therapists and other parents, Milo was starting to get heavier by then. I was also so excited to see her sitting in a buggy, being able to take her home. It was a great moment in my life. I was so happy and comfortable to feel free. It was a very, very good day. And I remember this day as yesterday when she was seated and they were off, and like how proud and excited she was to actually go and show the family and get along. So you can even see on her face that was really, really a great day for her. So you can move to the next slide. What's so important, you can move to the next slide. What's also, it's linking back to the previous slide, they also explain that it's so important to continue with this journey of AT, because they're explaining some parents give up. They think, what is the use of me going to the clinic? What is the use of me going to the physiotherapist? My child is not improving. There are parents that feel that way. It's so important for them to understand that all these interventions are important for the child. It's for the child's body to get to the physio for exercise. And at the clinic, you get to talk to other people. So again, they're highlighting the story that that AT is I mean, even in their quote, what they're saying, it literally changed their lives. But it's also about going there, understanding why we need to go back, and then the benefit of being able to talk about what's happening. And then just again the reality check for us where they explain sometimes if we're going for a date, I must remember to get up on Monday and go to the clinic to get a date because sometimes they forget to call us. I share this information with other mothers so that they know what to do and how to get support for themselves and their children. And then again, the last bit here for me also, it really it's home when she said, as a mother, I also pay attention to how different therapists work with Cleo. Sometimes we get new therapists and they don't know how to work well with her in any case. So I pay attention and ask them questions. And what's so amazing here for me is that, or so important here is in the Northern Cape in particular, we had as every year went by, we had so many ComServes coming and going, and that what they explain how important it is to actually for the parent to be the person who's, you know, the constant, who's actually then taking the information to the next therapist. So on the next slide, they also explain. You can move to the next slide. They also explain and reflect on learning and play. Where they say that the teachers didn't know much about disabilities and how that really influenced the way that their kids learn. And they explain that in Ritchie or in Route 1, as I explained earlier, not many children with disabilities attend school. And that in general, really, in my experience, is that simply there's just not a school. It's not as if they don't want to take their kids, but also they reflect that there's no community support. So that was something similar that they mentioned in the beginning when we talked about perceptions of disability, where they just say that sometimes children refuse to go to school because they're scared they will be making fun of. And then again, they're just saying these are things that we have to teach parents, teachers, and children about. What was really important and what we did in this project here is that we tried to make the link between assistive technology and learning. So in particularly, we wanted to raise the awareness, how do we see children for play and learning, and that it's not just about seating so that the child can sit, but how is it appropriate so that they can actually participate in learning. So you can move to the next slide. Then the last bit here, I wanted to reflect on. At the time of the project, we haven't had the parent network, but what they talk about is really important, which was also growing more and more important as we build the parent network. So these two mothers met each other at the clinic, and they live in this small town that I explained earlier, but they didn't know about each other. Which talks to so many of the aspects that we reflected on. But what they say here, Anita says particularly, she says, there's no parent of a child with a disability that can cope without support. It is actually quite impossible. They need to know that they are not alone. And then she explains, and I would want to finish off with this, where she says, so I want to ask parents to love their children and to look after them and to ask questions when you are at the clinic or at the therapist. You have the right to ask questions. Like I've said before, you are your child's mouthpiece. So beautiful for me how she explains that. And then you can go to my last slide. I just wanted to end off by, you can go to the next slide, by linking where we started with what's the ecosystemic approach to assistive technology, where she says where she says the biggest difference for Cleo is that she is more comfortable. Though we waited about 5 years for her device, and I still struggle to get her into it, we are able to get her to the clinic if we need to go. Now we can all sit at the table. We can go to the church, and she can go to the center. When we are out, Cleo loves interacting with people in the community. We are also able to get go to the clinic if we need to. So what's important for me, and maybe to end off with that, is that assistive technology cannot be provided in a vacuum. It's one very important cog in the wheel, but it's definitely one of that to make inclusion within an ecosystemic approach happen. So I hope that's 2 stories that I wanted to share with you about assistive technology in health and from an ecosystemic approach. Thank you, Sarona. Over to you.
Thank you very much, Erna. Yeah, I don't think I have to summarize because you summarized. Thank you very much. I just want to, I think this is an hour and a half, so I think this time, is there any questions or comments or something that somebody wants to add or share with either Erna or Ilana? No, or me, but mine was just the introduction. Yeah. Chanel just also said in the chat a reminder to please complete the attendance and CPD points register, and she gave the link there. So anybody who hasn't done that yet, please just complete that. Joel, yes, please, you can speak. You can unmute yourself and speak up.
Yeah, thank you so much. And I should really appreciate you all for the good presentations that I've made. Now, I have got maybe about two or three concerns. I'm from Malawi, and I think mostly that is the environment of South Africa. That's the one which has been presented so far, and it's impressive, I should say, because when you talk about assistive products, like here in Malawi, there are so many challenges that are there. But I said there's a good support system that is there in South Africa that is comparing to what we're experiencing here. You look at the case of Elana, without support, I'm telling you that one will not be where it is. And this is so amazing. I just want to ask what policies or strategies are there in South Africa with regard to assistive technology, like the ones, if they are there, the ones which at least facilitate a good support, which is also there. And also looking at the source of assistive products, most in the developing countries, we rely on mostly should be donations because they are so many expensive. So they are very expensive for an ordinary person to acquire, just like what has been presented. What is the main source of assistive products in South Africa? Do you have a specific budget line that's saying that this one really covers for procurement or whatever of assistive products, or are they fabricated, or are there some or do you rely on donations just as many as we do? Last, looking at barriers, these ones are also affecting maybe the use of assistive products in countries. Do you have I understand the international standards of universal designs, like you talk about in transport, buildings, and the like. Are those designs in place in South Africa? Because here we are not yet using those. But for the good, the way you have shown, are you using those ones, or you have adapted them into your own setting? Let me stop there. Thank you.
Thank you, Joel. Okay, I'm going to, Anna, I'm going to ask you to please deal with the policy part of the question, because that's very much your part of your work. I would quickly respond regarding the funding part. In South Africa, assistive technology is mainly funded through the government, mainly funded through the Department of Health. and then also to an extent Department of Education, because it is part of our health system, and about 80% of our citizens use public health care, and they would then get their assistive devices through public health care. But there are budget limitations, obviously, and there are challenges. So certain devices, for instance, there would be a tender, either provincial or national tender, and devices can be bought off the tender and people can get what they need. Other devices, other components, for instance, I'm thinking prosthetics now, you don't have a tender and they have to do buyouts and they have to get free quotes and things like that. So it's all different. And then it's definitely not that much money. So the more expensive devices, and like in Ilana's case, the government will not fund that. There isn't money for that kind of funding. So you have to make a plan and raise funding, and very often people have to do without the more expensive devices. But for the basic assistive devices, maybe if I can talk about the WHO list of 50, which is the 50 essential devices. Those devices you would get through government and government would fund it. We don't have that much donor funding in South Africa. I know it's a much bigger thing in other countries in Africa. So let me stop with funding there. And then I'm going to ask Anna, would you like to talk about the policies in South Africa regarding assistive technology?
I can try.
Thank you. I thought you would want to.
So it's really interesting because, okay, let me start with South Africa. We don't have like proper overarching policy in South Africa, particularly in terms of assistive technology. And what's really fascinating is there's a 2-day national machinery conversation going on today and tomorrow. And even this morning again, it was confirmed that the white paper on the rights of persons with disabilities remain the kind of the policy framework in South Africa with its implementation matrix. But the challenge with that is that it's not law yet. So there's no, by lack of a better word, but a consequence if that implementation is not happening. So it is an ongoing challenge. We can't really keep anyone accountable for not having those or not providing assistive technology. And we must also remember that the budgets there's no ring fence budgets, maybe to explain it like that. 480, it's like a collective. So in other words, there will be all health services will be in a big bucket of money, by lack of a better word. The other parts that's on my mind as you spoke about Malawi in particular. For instance, I had a meeting today with somebody who's keen to work in Uganda and Zambia and other African countries. And the closest example I can maybe give of sort of work in broader Africa would, for instance, be in Botswana, where over many, many years of work and sort of advocacy work, we eventually facilitated a process where Botswana, for instance, now also have a tender process. But that's a very long-term sort of relational process, by lack of a better word, where it's kind of like you start seating children or assess children, seat them, and through doing that, you kind of do the advocacy work to get that in place. But it's certainly a very long process. It's not something that's happening within a short span of time. But in terms of local provision, it is really a challenge when big INGOs come in and really provide very cheap devices. I mean, I've seen very recently like white garden chairs, those plastic garden chairs literally being fitted with 4 wheels, and the damage it's making is really, it's really far, like it's big damage. So part of that, I guess, is all of our work to advocate when we see those devices, to try and raise the awareness of what is the appropriate device. Just because it's in Africa doesn't mean we need to, you know, take any device. We're still there for quality and advocate for local production. I mean, that's one of the biggest challenges that we are facing, where yeah, this whole quality issue, because we're in Africa, that it should not necessarily be of quality. So I hope I answered a little bit. But I see Serona also asked Ilana to take us through some more of the issues.
Thank you, Erna. Yeah, the last part of Joel's question was about universal design and whether it is implemented in South Africa. If I understand whether you would like to take that part of the question.
Hello. Okay.
Hi, yeah.
Okay, that's quite a difficult question. Yeah, whether South Africa has implemented universal design principle. Well, like an example, I'll just give a real life example. For like a restaurant. It's not. Well, one day I was at a restaurant with one of my teacher, and it was so noisy, and it's the buildings were like wasn't acoustically built, so a mess everywhere. So I don't think in the whole of South Africa. I don't have to answer the question. I'm not sure what it is it specifically education or in other buildings.
Joel, did you have a specific aspect of universal design in mind, or was it just in general? I think in Ilana's, in general, we have policy, but no, it's not implemented, and no, it isn't really happening. But if you want a specific something, then yeah, Joel, you could.
Yeah, well, thank you so much. I think it's not.
Yeah.
It's not that specific. It's just general, because from what you presented and also what you showed, there were some, I think, better environments, and I was curious if that is coming from maybe the implementation of those universal designs which are there, advocated for worldwide. But that is generally, if they are not fully implemented or partially, that is okay. But that is just out of interest because of the good scenario that you have shown. Thank you.
Yeah. Thank you, Joel. Yeah, I think that is the things that Ilana showed, especially those two schools that she went to as a young child, was very definitely is the exception. It is special schools that were specially designed for specific needs, but generally in public buildings in South Africa, yeah, it isn't really implemented to a large extent. I think that is the short answer. Is there any other questions? In the chat, there's just it's just people congratulating you, Ilana, and saying thank you to you. Quite a number of people responding to your talk. Yeah. If there's no more questions, then Chanel, I'm going to hand over back to you. And yeah, I want to say thank you very much to everybody for being here, for being part of this. Thank you to Anna and Ilana, who I could just ask, and they said yes, they will participate, and we could put this together. Thank you very much. And yeah, Joel also saying thank you in the chat. Somebody saying great presentation, Erna. So yeah, Chanel, over to you. Thank you very much.
Yes, thank you, Dr. Vasahi, and thank you so much, colleagues, for those wonderful presentations. I just want to remind everybody to please, if you are going to register for CPD points, please to follow the link and do so. And yeah, enjoy the rest of your afternoon. And the recording will be uploaded to our website probably by next week. Thank you.